Thank you for joining us for today's PAA Presents webinar in collaboration with the UPMC Hillman Cancer Center, Taking Care of the Skin You're In. My name is Lauren Bostito, and I am the Assistant Director for Constituent Relations at the University of Pittsburgh. Before I hand things off to our moderator, an extraordinary panel of doctors, I do have a couple of logistical notes. So as always, I want to thank you in advance for your patience with any potential technical issues. If you do have technical difficulties, please visit support.zoom.us. I'll also note that you won't be able to turn your video on at any time, but there is a Q&A box located at the bottom of your screen. Please feel free to ask your question at any time. Any questions or comments that you type will be visible to our moderator and our panelists, but not to other attendees. You are encouraged to ask questions throughout the webinar. Our doctors will present for around 30 to 40 minutes, and we will address any immediate questions that come in. We will have time at the end to get through an overall interactive Q&A for all of the panelists. So at this time, I would like to start by introducing our moderator for today, Dr. Monica Baskin. Dr. Baskin is the Deputy Director, UPMC Hillman Cancer Center Professor of Medicine, Division of Hematology Oncology, and School of Medicine, Assistant Vice Chancellor for Community Health Equity, Health Sciences at the University of Pittsburgh. Welcome, Dr. Baskin.
Thank you so much, Lauren. And certainly that is a mouthful, lots of different titles. But I am particularly proud and honored to serve as the Deputy Director for our Comprehensive Cancer Center here. And one of the reasons why I'm so excited about that is I get to work alongside these wonderful panelists that you'll hear from today. So collectively, we are really focused on how we can really, discover new ideas and ways for us to prevent cancer, as well as to treat it for those who end up with the diagnosis. So without further ado, I'll introduce our esteemed panelists today. First and foremost, Dr. Laura Ferris, who is joining us as a professor of dermatology here at the University of Pittsburgh. She is also the Director of Dermatology Clinical Trials at UPMC. She directs the Pigmented Skin Lesions Clinic and is part of UPMC Hillman Cancer Center's skin cancer program. She has been the principal investigator on more than 120 clinical trials of novel therapeutics, and she's going to share a little bit about some of that work. She also works on diagnostic tools for dermatological diseases such as psoriasis, atopic dermatitis, and skin cancer. She's authored more than 100 peer-reviewed publications, and she has a very strong interest in cancer screening and leads our UPMC's involvement in a large national multi-cancer early detection clinical trial program. That's certainly one of the things that I think might be game-changing in terms of how we identify cancers much earlier, where we know we can have better options for treatment. In addition to that, we are joined by Dr. Yana Najjar. Dr. Najjar is a translational investigator and medical oncologist at UPMC Hillman Cancer Center and an assistant professor of medicine and the director of the Clinical and Translational Research Center at the University of Pittsburgh. She specializes in the treatment of advanced melanoma, and she uses a bench-to-bedside approach where she's developed multiple investigator-initiated clinical trials that aim to remodel melanoma tumor cell metabolism as well as hypoxia in the tumor microenvironment to overcome mechanisms of resistance to immunotherapy. Her lab is focused on various correlative analysis from these trials, and her work is funded by the U.S. Department of Defense, the Melanoma Research Alliance, and the National Institutes of Health. So with that, we will start with Dr. Ferris doing her presentation. Again, as was mentioned at the beginning, feel free to put in your questions in the Q&A section, and we'll moderate those, and we'll have questions immediately after Dr. Ferris, and then we'll move over to Dr. Najjar's talk. Again, she'll answer some immediate questions, and then afterwards we'll certainly hope to have enough time to open up any questions for both of our panelists. Thank you, and Dr. Ferris, please go ahead.
Thank you so much, Dr. Baskin. Thank you for having me. And it's great to kick off May, which is Melanoma Awareness Month, with a session on melanoma. So I'm going to be talking about sort of I'll talk about a little bit about skin cancer because we can't talk about melanoma without mentioning the other skin cancers. And then I'm going to be talking about what is melanoma. It's sort of on the early detection and screening phase. And then Dr. Najjar is going to talk about treating advanced melanoma. So just as an overview, I'll talk about the common skin cancers, basal cell squamous cell carcinoma and melanoma and dysplastic nevi. And then I'm going to actually talk about this multi-cancer early detection test. So just going to start with, basal cell carcinoma. This is the most common cancer in human beings. It is if you live long enough, you have fair enough skin, you spend enough time outdoors, chances are better than not that you'll end up with the basal cell carcinoma. These fortunately are, I tell my patients, if you must have one cancer, the one you'd like to get, because they are very rarely metastatic or deadly, although we occasionally do see some very bad basal cell carcinomas. They are primarily caused by sunlight. They are generally present as a pearly bump or a scaly spot on the skin. They do occur most commonly on the face because that is such a sun exposed area, but you can see them anywhere on the body. These are all different pictures of different basal cell carcinomas. Squamous cell carcinoma is our second most common skin cancer. Of the non-melanoma skin cancers, it really causes the most deaths. And interestingly, as our treatment by people like Dr. Najjar for advanced melanoma has improved, and we've seen a little reduction in melanoma mortality, we actually see about as many patients dying now from squamous cell carcinoma as we do melanoma. It's starting to catch up. However, the vast majority of squamous cell carcinomas of the skin are not aggressive, and when caught early are very treatable. The patients who we really worry about with squamous cell carcinoma are our patients who are immunosuppressed. This is often, particularly in Pittsburgh, patients who have had solid organ transplants, and these patients are at very high risk of having squamous cell carcinomas and having more aggressive tumors. These are the patients who I think we end up worrying about oftentimes the most in our tumor boards. And these are different examples of squamous cell carcinomas. They tend to be more kind of red or pink and crusty. They have this sort of hyperkeratotic surface that you can see here. How do we, when we diagnose basal and squamous cell carcinomas, generally, I'll ask my patients when they come in to see me, do you have any sores that don't heal or bleed with minimal trauma? And if we suspect that that a patient has a basal or squamous cell carcinoma, we'll generally do a skin biopsy. And that is just for the purpose of getting enough tissue to make a diagnosis. The next thing then we'll do is treat, and I won't go into a lot of this. When we're treating localized disease, we will generally do something called a curettage and electrodesiccation for the most superficial skin cancers. That doesn't involve any stitches. Sometimes we'll do an excision where we cut out the entire area. We send that tissue out for the margins to be looked at. And then for some patients, we'll do Mohs surgery, which is where I don't do this, but I have colleagues who do this. We remove all of the visible tumor. We mark it out, and so we know exactly what margin correlates with what area of the patient. And then we can go and very carefully clear away the entire tumor, and then the patient is closed. So this is not for every tumor. It's primarily lesions that are on the face, lesions that meet certain criteria of being higher risk, or where we think just a basic excision will not be sufficient. Okay, so that's my overview of the most common skin cancers. I'm going to now move on and talk about moles and melanoma. So, these are all pigmented skin lesions. So they are derived from the melanocytes, or the pigment producing cells in the skin. And I really think of these as existing on a spectrum. So from this very benign light brown mole that's on my forearm that has never changed, to this very atypical, irregular, obvious melanoma on the right. So the majority of moles are benign nevi, and they will not, they grow minimally. They don't progress to melanoma. They're usually one color, symmetric, have smooth borders. And if you ask a patient, they haven't changed recently. Sort of the next step on that spectrum are dysplastic nevi. These are moles with some clinically atypical features. The vast majority of these really don't need to be removed, or if they are removed and we get a biopsy, we don't need to go back and do an excision or treat them. If you have one of these, talk to your dermatologist about it. Some that are very atypical, or that we have concerning features that, they look like they may be moving toward that melanoma end of the spectrum, we may go back and re-excise. These are not, sometimes patients will say, I had a pre-melanoma or a pre-cancer. These really are not pre-melanomas or pre-cancers. They are just one of the pigmented lesions that lives on the spectrum of the many pigmented lesions that most of us have. And now I'm going to move on and talk about, what is melanoma. So this is the malignant end of that spectrum. These are all examples of melanomas. So it's a tumor that is, so what is it? It's a tumor of cells that make the pigment melanin. This really does cause the most deaths due to skin cancer. And these are two examples of two different looking melanomas. There's multiple different subtypes. And there can have varied appearances. Just a few basic statistics. Sorry for the little bit of a gross foot picture, but I put these two pictures on to show the incredible variability in melanoma. The top one is an early melanoma in situ. It barely looks atypical. The bottom one is a very advanced nodular melanoma on the foot. There are about 100,000 new cases of melanoma every year. But melanoma makes up 5% of new cancer diagnoses each year. And it's estimated that in 2024, there'll be around 8,200, 8,300 patients who die of melanoma. And that's about 1.4% of all cancer deaths in the US. The 5-year relative survival is about 94%. So what does this mean? It means that there are many more melanomas than there are deaths. So not all melanomas are fatal. And it actually means that most patients with melanoma will do well. However, we do know that, there is that subset of that 80 to 90 of patients who will die. For each one of those, there are patients who have advanced disease who will be, need to undergo very aggressive treatment. So, we really try to think of melanoma as, when we find this early, if a patient has a lesion that's growing and changing, why do we want to find it early so that we can hopefully, have somebody in the, I just need a surgery and I'm done category, rather than, needing to use some of the more advanced therapies that we have. Risk factors for melanoma: sun exposure, like all our other skin cancers, patients who have fair skin, blonde hair, freckling, patients with a lot of moles, while there are greater than 100, we know are more likely to be diagnosed with melanoma. It doesn't mean that every mole is a ticking time bomb. It just means that's sort of a marker of somebody who might get melanoma. Family history of melanoma, having a personal history of melanoma in the past means that you're more likely to get a second one. And then, as with many cancers, the risk of melanoma goes up with age. And, once you get over 50, your risk of melanoma starts to increase slightly. When we talk about diagnosing melanoma, back in the 80s, dermatologists came up with this mnemonic, the ABCD. So asymmetry, borders that are irregular, color variegation or multiple colors, diameter greater than 1/4 inch or 6 millimeters. I tell patients a pencil eraser. As we have learned more about melanoma, we've added in other features. So now we do E for evolving or changing, and then ugly duckling. That's something that I think we can all relate to. If you just stand back and look at yourself or at a patient, and I say, man, that mole does not look like any other ones, that is predictive that is maybe one we need to take a closer look at. And then regression, which is this white area in the middle, which is actually the immune system realizing that these cells are cancerous and atypical and starting to actually attack and kill them. But I will say, as time has gone on, really it's the evolving and ugly duckling features that I think are most important to be thinking about. So, rapid visible change is really a sign that that's a biologically relevant lesion that should get attention. And I just put in here, these are all different pictures of melanomas showing that it can have different appearances, pointing out that this, on the top panel, you can see this melanoma of the nail unit going onto the finger. So you can get melanoma in areas that are not sunny, or that you wouldn't think of as being sun exposed. So fingernails, toenails, particularly in our skin of color patients. On the palms and the soles also are areas that can get melanoma. It's rare, but those are more common in our skin of color patients as well. You can also see there's a pink lesion here that maybe you think that looks like the basal cells that I showed you earlier, and it does, but that is an amelanotic melanoma. So most melanomas will be pigmented, but some of them will actually not make melanin, and they will be more pink or red. These are just a few more pictures of melanomas that we've biopsied over the years. So melanoma starts at, there are different stages of melanoma. So some melanomas are in situ, meaning that they sit at the top of the skin. They don't invade into the dermis or the sort of bottom layer of the skin. And that is melanoma in situ. These melanomas really are surgically curable. They do not overall metastasize. Some of these probably very rare. Some of these probably don't progress to be invasive. Some of these will progress very, very slowly. So melanoma in situ is the earliest. We call it stage 0 melanoma. Then melanoma can become invasive. So this is when it grows, through the epidermis down, invades into the dermis. It may have an ulcer where the cells are dividing so rapidly that they actually start to break the top layer of the skin. This is where the risk of metastasis increases. And when as tumors get thicker, particularly we think of tumors thicker than 1 millimeter as being at increasing risk of metastasis. So when we say a patient has stage 3 melanoma, that generally means that tumor has moved beyond the skin and has gone to, the lymph nodes. Generally, melanoma metastasizes most commonly through the lymphatics, or so through the lymph nodes, but it can also metastasize through the bloodstream without involving the lymph nodes. And then stage 4 melanoma is advanced melanoma. So this is melanoma that has gone beyond the lymph nodes, or is in areas like, the organs like the brain, the lungs, the liver, the bowel, the bone. And so this is really the most sort of highest risk of death from melanoma comes from when patients have stage 4 melanoma. So I'm going to talk a little bit. So that's sort of the idea of melanoma. So, I've done a lot of focusing on, talking about how there's different stages and there's earlier, detection. So certainly we want to find melanoma earlier. We don't want to give it a chance to go deeper into the skin, to metastasize to lymph nodes, to metastasize to distant organs. And so really a lot of my time as a dermatologist, and as we found a lot of time of dermatologists in general, is spent doing, full body skin exams, screening for melanoma. And what is interesting is that we actually, despite the fact that we do a lot of this, and when we go looking for a lot of melanoma, we actually don't have any solid data to show that we're preventing melanoma deaths. So this is just sort of a high overview of, there was a study that was done in Germany. It was published back in 2012, where Schleswig-Holstein, which is that central state in Germany, that's SH on the map, had an initiative where they trained physicians, dermatologists, and primary care doctors how to do skin exams, how to find melanoma early, opened up melanoma screening to the general asymptomatic population. And then they looked sort of pre-intervention. The intervention was around 2004. They looked pre-intervention at melanoma mortality rates in Germany. That's on the left, and then post, which was on the right. So darker color means higher rates of melanoma mortality or death. Lighter color means lower rates. So our first kind of look at this data showed that, Schleswig-Holstein in the center actually got lighter. So it looked like there was a reduction in melanoma mortality. I think we all thought this is great. This showed us that screening is probably playing a role. And so then screening became, opened up, and the Germany as a nation started doing screening for population-based screening for melanoma. And what they found is that 2004, 2005 is that vertical box. That's when the screening was. And then they looked at effects on death. And they actually found that although we saw this initial decrease, all of the mortality rates came back up to baseline. And in all of Germany, there really was no impact. So this was a little bit of a disappointment to those of us who were hoping screening would be the answer. But it's really kind of led me to think a little bit more about what is the best approach to reducing melanoma mortality. And so, the United States, we have a thing called the United States Preventative Services Task Force, and they weigh things like, cancer early detection or prevention. So they're the people who give guidance on mammograms or PSA or colonoscopy, and they have looked several times at the data that exists throughout the world, and they have said that we really have an I rating, meaning insufficient data or guidance insufficient data to support population-based screening for skin cancer in asymptomatic people. So that doesn't mean supporting following up patients who have had melanoma or who we know are high risk, but sort of the general population. So, I want to address a few of these issues and kind of think about what does this mean for us as this field? What does it mean for patients? And how should we think about it? So I think one of the interesting things that we see is that if we look at who gets melanoma, it's older people, it's men more than women. And interestingly, having a higher socioeconomic status is associated with a higher incidence or rate of being diagnosed with melanoma. If we look at who dies from melanoma, it's also older people. It's also definitely more men, but it is our patients with lower educational attainment and socioeconomic status who die of melanoma. And then if we look at who tends to get screened for melanoma, it's younger people, it's women, and it's highly educated and wealthier patients. So I think sometimes our screening message has kind of reached the wrong population. And so probably a lot of our screening actually happens in patients who are at the lowest risk of melanoma death. And in fact, when we look at changes in skin cancer screening rates in the United States, this was a study that I did with one of my fellows recently. We looked at national health interview study data, and we found that skin cancer screening or total body skin exams has been increasing over time, but it's actually mostly increasing among women, younger patients, wealthier patients, and more educated patients. So there is a little bit of, missing the mark on those people who are most likely to die from melanoma. The other thing that's, interesting. So what, maybe you're doing too much screening, what impact does that have? Another, study that was published and that we wrote an editorial on was this one about the time it takes to find one skin cancer by screening, asymptomatic patients. And it turns out that if you just take a group of people coming into dermatology, not worried about skin cancer, and you screen them, you'll find skin cancers. And they timed how long that takes. It takes about 4.5 hours of dermatologist time to find one skin cancer of any type. And the time to find one melanoma is about 38 hours. So, one of the things that this has really gotten me to think about, if any of you have ever tried to get in to see a dermatologist in Pittsburgh, you probably know that it takes a really long time. Our access is terrible. And it actually turns out that probably part of the problem is we do a lot of screening of lower risk patients who don't have anything that they're worried about. And then it actually makes us not available to see our patients when they do walk in. And so this is my patient on the right who really made me think about this. This is an 89-year-old lovely man, military veteran, doesn't have my cell phone and my email and the ability to jump on to, schedule appointments online. He just called the phone room and waited 9 months for a dermatology appointment. And then when I saw him and took this off, I actually saw him earlier because his primary care doctor did pick up the phone and call me, but he had a 2.6 millimeter ulcerated melanoma. This is a more advanced melanoma that is at much higher risk of metastasis. So it really made me think, gosh, I spent so much time screening patients who didn't have anything, and this poor man wasn't able to get in to see me. And I'm not alone. This is looking at the average wait time by state to see a dermatologist. So, on average in Pennsylvania, it's only 20 days, but it's, upwards of 60 days in some of our or 80 days in our more rural states. So this has kind of led me to think about what could we be doing. So, I've done lots of studies of diagnostic tools and devices for using AI to evaluate maybe a single lesion But, you know, that doesn't really get along to say, should this one mole be biopsied, yes or no? And I think after, you know, the experience of a dermatologist, we maybe don't need that. But I thought, you know, what would be really helpful is to find new or changing lesions. And so, you know, we say, you know, when it comes to, you know, what is the definition from the National Cancer Institute of Cancer? It is uncontrolled growth of cells. So if it's not growing, it's not changing, you know, we actually know that that's not really behaving like cancer. That's not biologically relevant cancer. And so, you know, to me, the advances we've had in AI, I think really presents us the opportunity to think about, instead of having one person look at the body, you know, can we harness serial imaging and use AI to look at newer changing lesions? And there are some tools out there that do it. They're really not well validated, or we don't have a lot of data to show. We've got sort of anecdotal evidence, and we've got, you know, some examples of seeing, you know, we can do this. But I think this is really where I would love to see us push, you know, this is where I'd love to see us push, you know, more research. This is an example of, you know, 2D or 3D. The one on the bottom left is this you know, this basically big imaging device that can very rapidly, you know, put the patient stands in the middle of this. They can look at, it can scan all of a patient's moles, you know, quantify them. It can, if you go back and get this done 6 months later, it'll match up your old moles, you know, your current moles with what was on the imaging. It can find new moles. It can find changed moles. It can, you know, look at all your moles and find the ugly duckling or the outlier. So I really feel like technology like this is going to change our ability to look and find truly biologically relevant tumors. This was a study comparing a 2D device with the 3D device. They're the two shown on the left. The big black dots are all melanomas. And so we can see that the 3D lesions were, you know, the 3D device, for example, it accurately found all but one of the melanomas, just by, you know, and this was not even looking at serial imaging. This was just trying to pick out the most atypical lesions. The 2D device did almost as well. Interestingly, the majority of the lesions were found by both devices. So I really think that there's a lot of potential in here, particularly with more, you know, research. And then also computers. This is another system that's been shown to be able to find, you know, simply just picking out the ugly duckling, looking at a back, saying, you know, this is the most atypical lesion. And then, you know, once we have the screening done and the most, you know, concerning lesions identified, getting those patients triaged to get in to see dermatology or even primary care, somebody who can evaluate and do a biopsy. So I really think this is potentially the way of the future. There's a lot of, you know, abilities to do this. So you can imagine that it's probably easier to make an appointment to get in and get into a machine for 90 seconds than to, you know, make your schedule match up with, you know, a dermatologist with limited ability. I think it actually will let us do some more screening by telemedicine, or remotely. It'll let us, you know, get to patients who are, you know, out in remote areas, for example. I also think it's going to really preserve that precious resource of physician time. And also, you know, I could give a whole nother talk on what's a biologically relevant melanoma and what's, you know, probably something that isn't biologically important. But I think this will really hone in on finding the growing, changing, biologically relevant melanoma. So this is where I think the field is going to be exciting, you know, to move into. And then, you know, I can't, as a dermatologist, talk to you without mentioning prevention. So I think we can all agree preventing melanoma, that's a win for all of us. And we really only have, I think, one really good skin cancer prevention trial that was very simple, but really informative. Queensland, Australia has the highest rates of melanoma. So in this study, they picked 1,600 people between 20 and 69 years of age. And they basically said for half of them, here's some free unlimited SPF 16 sunblock, which is not really even what we would use now, but this is a while ago. They said, put it on all your sun exposed skin whenever you go outside. And the other one, the other group, they just said, you know, protect your skin like you normally do. And then they followed these patients and they looked looked at the number of melanomas that they developed over time. And so what you can see here is that the yellow group is the one who just said, practice, you know, go carry on as usual, and the blue group is the one that got sunscreen. And we can see that the risk of melanoma was reduced by 50% in that group who was given and used sunscreen regularly. And invasive melanomas, the ones that we know are most likely to metastasize and cause problems, were actually reduced by 73%. So to me, this is fantastic data that sunscreen does work to reduce melanoma. All right. So I'm going to now just change gears, and I'm going to talk about, so I kind of talked to you about why sometimes screening is hard, and particularly when you have labor intensive screening. So, this has led me to working on my next topic, which is multi-cancer early detection. So this is, what if you could go get one blood test and it could screen you for 20 or more cancers? And so there are a couple of these tests out here, and we're actually doing a trial of one. The trial is called Pathfinder 2. I'll talk about it. So this is a single blood test that looks for what we call cell-free DNA. So tumors, with their growing in the body, even before they're symptomatic or noticeable, will shed, tumor cells and shed tumor DNA. And it turns out that, when you just by drawing a tube of blood, we can actually look for these fragments of DNA. And, we can correlate these, not just to say, this looks like it came from a tumor, but actually to say, this looks like it came from a tumor, and we think that the origin is breast or lung or ovarian or lymphoid or melanocytic. So, looking for melanoma. And so, basically a patient can get this test, and either they'll get good news, no cancer signal was detected, or there was a cancer signal detected, and we think the origin might be colon, for example. Then you can go work that patient up or screen them for colon cancer. And so this was the first version of this test, called Pathfinder. It was a prospective study of over 6,500 patients. And then basically, if a patient had a positive test, they were worked up for cancer. And if they had a negative one, they were followed over time. And just to give you an idea, of those 6,600, of those about 1%, 1.4% had a positive test. The majority were negative. Of those, we can see that 35 of those, so a third of those, or 0.57% of all patients, had a true positive. And then there were also 0.86% that had, those were false positives. They turned out not to have cancer. And then of those with no signal detected, only 0.13% of patients actually ended up over the next 3 years developing cancer. So seeming to be promising. And these are the cancers that were detected. I mentioned the USPSTF. You can see that many of them in blue are really cancers for which we have no screening available. So I think that this is exciting. We're working on Pathfinder 2, which is a multi-cancer early detection test, where we are enrolling. We're just one site of many. 35,000 people 50 or older will get the blood test done. And if there is cancer signals not detected, we follow those patients every 6 months for 3 years to see, did they develop cancer? Did they, keep up with their mammograms, pap smears, colonoscopy, et cetera? And then for those patients who do have a cancer signal detected, we will then look at their signal of origin, and then actually look and see, do they, are they diagnosed with cancer? And if we don't see anything, actually get a PET CT and follow them and see if there's any cancer anywhere. If negative, continue to follow them. So, these are the different lineages that are looked at, lots of different cancer types across multiple different lineages, many of which there's no screening for. And then I'll just end with this. So this is Pathfinder 2. So I will put in a little plug if anybody is interested. We're basically just looking for patients who are 50 years or older, who have not been diagnosed or treated for cancer in the past 3 years. It's one in-person visit for a blood draw, and then questionnaires periodically, and interviews every 6 months to see if you have been diagnosed with cancer. And I think what's helpful, we're really trying to get a diverse population of patients. This study will actually pay for the workup of cancer, and that maybe 1% that ends up with a positive test. So, please keep us in mind for that. And so that QR code just gives information. You can provide information if you wanted to learn more, but this is the study. So I'm going to end with that, and I'll stop sharing, and I'm going to pass it over to Dr. Najjar.
Great, thank you. So it just in the meantime, we do have a couple of questions, but we'll save those to the end after Dr. Najjar's presentation.
Okay, wonderful. Thank you, Doctors Baskin and Ferris. I will share my screen. Is that working okay?
Yes.
Okay, wonderful.
Oh.
Hi, everybody. Thank you
One-
so much.
One quick
Sorry,
thing, it's in the presenter mode. I mean, it's not in presenter mode. Yeah, there you go.
better?
Perfect.
Okay,
Yes.
thank you. I have two screens and I never know which is showing, so thank you. So I'm a medical oncologist, as Dr. Baskin said earlier, and I'm very focused on melanoma. With few exceptions, it's really the only disease that I treat in clinic. And so what I wanted to do today was try and give you a flavor of the treatment landscape. And I appreciate that this is not a medical or a clinical audience. And if I devolve into gibberish at any point, by all means, please let us know in the questions, but I certainly will try my best not to do so. So today we'll be talking about how we manage melanoma, because that has changed wildly in the past few years. But on the other hand, it has also changed quite slowly. And what I mean by that is, if you start to think about, I really love history, so I look at everything from that perspective. If we think about where we started and the fact that you had descriptions of mastectomies back in ancient Egypt, you can appreciate, I think, how far we have come with the advent of not just, being able to safely do surgeries, radiation, chemotherapy, cell therapy, etc. And more recently, we are now in a completely new paradigm. The old paradigm for the management of cancer in general, and melanoma in particular, was to directly target the tumor. You either cut it out, you zap it with radiation, you hit it with chemo. The other side of that coin, of course, is you're hitting everything else. And the new paradigm is distinctly different. And specifically, what I mean by that is you're not targeting the tumor. The tumor is sort of not even the point anymore. You're targeting the patient's own immune system. And when I talk about the immune system, I'm referencing billions and billions of cells in your own bloodstream that keep you all from getting too sick when you have a cold or the common flu. And one could argue successfully that any cancer really is fundamentally a failure of the immune system. Why did this one cell manage to evade your immune system and grow into a cancer? Why does that happen in any patient? And so the current paradigm we find ourselves in is trying to galvanize the immune system itself to switch it on to go and fight the cancer. We no longer directly target the cancer, especially not in melanoma, with few exceptions. Now, Dr. Ferris, of course, alluded to the risk factors for radiation. This is a slide I always actually show our trainees because I think it's a really dubious honor. You can see here, we know very well that UV radiation is the #1 risk factor for skin melanoma. But you can see here in the study from 2009, when they looked at the number of facilities for tanning salons, Pittsburgh was #1, which explains, I think, in parts why, unfortunately, there are so many patients that are followed at this institution. The authors, to try and put the number of tanning salons in context, looked at the averages of Starbucks and McDonald's in the same area, and Pittsburgh was one of the few where this was higher than some of those numbers. And I would love to be mistaken, but I don't think this has gotten a lot better. It's still a very common misconception. People will say things like, I get a base burn, etc., which of course nobody should be doing. And the reason we all make such a stink about it is because we understand that this is really a deadly disease. It's the 5th most common cancer in men and in women in the United States. And the incidence has continued to increase, as Dr. Ferris alluded to as well. And this has been steady across the past several decades, but we're finally starting to see a downtick, and that's in the dark green here, in the number of patients who are actually dying of advanced melanoma. And that's really thanks to the advent of immunotherapy. So what is immunotherapy? I really just wanted to try and explain this in broad strokes, because I think it's impossible to talk about melanoma management in 2024 without talking about immunotherapy. And really what immunotherapy refers to is medication that goes in the IV that patients get, depending on the schedule, between every 3 to 4 weeks. And what these drugs do is they bind to certain markers that sit on the patient's own cells. So you can see here in blue, this is an immune cell, and in red, this is a tumor cell. And what happens normally is that when an immune cell and a tumor cell come together, the tumor cell finds a way to kill the immune cell. And that's what we mean when we say that tumor cells are evading or escaping the immune system. But what immunotherapy does is it stops that from happening. It stops the tumor cell from interfacing so closely with the immune cell so that the tumor cell cannot kill the immune cell, and the immune cell can do what it's supposed to do all along, which is kill the tumor. And there are multiple flavors, if you will, of immunotherapy. I won't belabor that point, but we now talk about first, second, third generation. In other words, there are 3 different targets of immunotherapy on immune cells that are now approved by the FDA for the management of melanoma. This is a slide that I really love, and it gives me great joy to update it every few months. The way that we treat melanoma has changed wildly. I can tell you, when I was in training now over a decade ago, all we really had at our disposal was chemotherapy, and unfortunately, it really didn't work very well at all. And since then, we have come to see multiple approvals from the FDA, and the reason that's important is because it means it's accessible to everybody, for various different treatments, either immunotherapy in blue, targeted therapy, which is a different kind of treatment that I'll come to in green, and even most recently, a very novel cell therapy. And I think one thing that is interesting to note is that these were all approved first in stage 4 for patients with metastatic disease. But such is the cycle of science. When we see that something works quite well in stage 4, we ask ourselves, might this work in stage 3 and stage 2? Would it allow us to keep patients from ever getting to more advanced disease? And the answer is yes. And so a lot of these drugs that were first approved in stage 4 are now approved in earlier stages of melanoma. And melanoma really has led the charge and been the first disease for which there has been FDA approval for all of these drugs. And that's really without exception. I actually tried very hard to find an exception to disprove myself, and I wasn't able to. And so just to give you a little bit of flavor, and of course there are major trials backing each of these up, but I won't get into that. Again, I'm trying to impart a flavor of what an exciting time it is in this field, because we're helping patients so much more than we've been able to before. The first and second generations of immunotherapy were approved in melanoma. The first combinations were approved in melanoma. We now have 2 different combinations of immunotherapy used in melanoma. We then were the first disease to say, can we use immunotherapy in stage 3 to keep it from advancing to stage 4? The answer was a resounding yes, with multiple approvals in that context as well. Now, when you hear about melanoma, the brunt of what you think about and what we see is skin melanoma. There's a much less common subtype. It accounts for about 5% melanoma in the eye. And we had no treatment for that really forever, up until a couple of years ago. And we had the first bispecific antibody. That's just a very long-winded way of saying it's a medicine that goes in the IV that binds 2 targets in the body at the same time. And that's now been approved and shown to extend survival for patients with this awful disease. We saw our first vaccine trial. This is an mRNA vaccine with immunotherapy that is decreasing recurrence in stage 3. And quite recently, and this trial was led here by one of my partners, we proved that using immunotherapy in stage 2 keeps patients from having recurrence. So I'm trying to show you that we went from stage 4 to stage 3 to stage 2. And so with all of that, we are seeing less death finally from this disease. And just a few weeks ago, we had the first cell therapy approved, lifileucel. The market name you might have seen if you follow this sort of thing is Amtagvi. And this is where a tumor is surgically removed from a patient. We remove the immune cells from within the tumor, you grow them by the billions, you give the patient chemotherapy, and you give them back their own immune cells. It's a really exciting modality, and it's one that's been a long time in the making, really since the 80s. And even in patients who are heavily pretreated, we are seeing nice responses in about a third. And this is a context in which we previously had no option. So this is a field that is literally changing month to month. So why has melanoma led the charge? That's really a very complex answer, but I think a very simplistic answer, and one that will help you maybe to understand why, is if you look at this, and this is a table to show us simply the number of mutations in the DNA of a tumor. How messed up is a tumor? How abnormal are the tumor genes behaving compared to a non-tumor cell? And you can see that melanoma is way up there, higher than anything else. And that's, of course, because of the UV damage. And so the fact that the melanoma cancer behaves so unlike the normal tissue in the patient has made this really a prime means, if you will, of getting the immune system to recognize it, because it's really quite fundamentally different. Whereas if a cancer behaves very similar to normal tissue, it's not so easy for the immune system to tell the two apart. One thing I will say, because I'd be remiss not to mention, is BRAF mutations, otherwise called targets. And this is important that I put it in just for completion to say that about 50% of patients with melanoma will have a BRAF mutation. And what that means is that there's a specific switch in the cancer cell that just stops responding normally. And this allows the cancer cell to basically go on and on and on with no checks or balances. And we have developed drugs over many, many years that target, I'm not sure if you can see my cursor, but that target the mutation itself and one underneath it, which we know makes the drugs work even better. And we have 4 different formulations approved by the FDA for patients with a BRAF mutation. I don't get into that a lot because based on a very elegant study, which we were involved in here as well, we know that starting with immunotherapy upfront is better, but this is an option for patients, certainly. So we've long known that patients with more advanced stages of melanoma are going to have a worse outcome. What I mean by that is, if you have a melanoma that's invading more into the deeper layers of the skin, if you have a melanoma that's gone to the lymph node, we know that the patient's going to have a worse outcome compared to a melanoma that's very, very thin. But for the longest time, we really couldn't do much with that information. It used to be that only patients with stage 4, up here in red, were treated with immunotherapy. And again, this is since about 2013, so relatively new. We have now done all of these very elegant clinical trials, which again, we've been all heavily involved in here at UPMC Hillman Cancer Center, to show that these immunotherapeutic drugs work well, not just in stage 3, but also in stage 2. So at this point, it's really only our patients with melanoma in situ, meaning a pre-melanoma lesion, stage 1 and earlier stage 2, who are not candidates for therapy. So you can appreciate that the top 2 tiers of this pyramid are eligible for immunotherapy. And this is one of the trials I was alluding to earlier, which showed that the likelihood of a cancer coming back, melanoma cancer coming back, are significantly decreased with treatment by immunotherapy. Now, one thing that really will never get old for me as a melanoma physician is thinking about this. I think about this multiple times every single day, and it never gets old. So the overall survival, meaning how long a patient lived, for patients with metastatic melanoma used to be under 6 months. There was no good outcome. There was no treatment, nothing good. And today, I'm coming to speak with you all here from clinic. I've already seen several patients today. We can tell patients that when they are treated with immunotherapy, 2 kinds of immunotherapy, you remember I said there are multiple combinations now approved, their odds of being alive at 7.5 years now are 48%. This was 49% at 6.5 years. And the thing I want to outline here, or highlight rather, is that the majority of these patients are cancer-free. We use the word remission. I secretly use the word cure because that's what I'm hoping for. But these drugs are relatively new. We don't even have a decade of data yet. But we see these patients all the time. Patients where it would have been a hospice discussion at any other time now have about a 50% chance of being completely freed of their disease with immunotherapy after 2 years of treatment. And that's just the most wonderful thing in the world when it happens, and we can, give that news to the patient. So the other side of that coin, of course, is that about 50% of patients are not benefiting from immunotherapy. And there have been multiple attempts and really innumerable clinical trials, literally tens of thousands of clinical trials that have tried to address this question. And there are many ways of doing this, looking at different medications, different combinations of medications, cell therapy, which I alluded to. And one thing that I'm very interested in, and my lab is very interested in, and I would say the field is interested in, is not just looking at the tumor, which is where we started. We're a little bit myopic in our scope. We started off by looking at the tumor itself and characteristics of the tumor. But as we've grown as a field, we've come to understand that it's really not just the tumor, but also the tumor microenvironment. And what I mean by that is the environment within which the tumor sits. What are the other cells there? What are they doing to the tumor? What are they doing to the immune cells coming in? What does it mean? Also looking at the host, the patient, the microbiome, the BMI. What other comorbidities do they have? And really looking at the interplay of all of this. And so one thing that Dr. Baskin had said is in her kind introduction was that I'm a translational scientist. And I wanted to explain what that means because I think it would really sum up what myself and all of my partners here do who are so focused on melanoma. It's taking this bench to bedside approach, which you might have heard. People always talk about bench to bedside. And what that means is you develop drugs with very sound scientific rationale, and then you give them to the patient. But what we really do is we also make the trip back. So my lab sits across the wall here. My clinic is across the hall. We will get human tissue. We will get biopsies from patients and blood from patients and bring it to the lab and ask a series of questions to try and understand why some patients respond and why some patients don't. And in so doing, we develop a hypothesis or a theory as to why that might be. And that allows us to develop rational combinations of drugs because, of course, you don't want to be throwing spaghetti at the wall. There has to be a very good reason that I think A and B are going to work, and I write it into clinical trial and give it to patients. And then what do I learn from the study and how does it impact what I do in the next clinical trial? It's this constant circular journey, if you will, from our basic scientists who are really developing a lot of the science. We then adopt it in the clinic, we bring it back to the lab here, et cetera, et cetera. And needless to say, that takes an enormous amount of teamwork, which is one of the many privileges of working here. So one thing that my lab has been very interested in, and I put this in because I want to give you a flavor of the work we do, is to study the metabolism of the tumor cells. And essentially, a tumor cell can get its energy one of two ways. It can chew up sugar or it can chew up oxygen. And what we've found so far is we think that actually how tumor cells utilize oxygen is really very important. And we published this finding a few years ago, and we found that patients whose melanoma tumors are just chewing up all the oxygen in the tumor microenvironment, meaning in the environment they're sitting in, are really not doing as well as patients whose melanoma tumors are leaving oxygen there for other cells, specifically immune cells, to work. And we showed that not only did these patients live for a shorter amount of time, less likely to respond to therapy, we also showed that the immune cells from these patients really weren't working very well at all. And this has sent us down this major rabbit hole, really, of investigation. We developed this clinical trial combining two different drugs to see, and again, this is what I meant earlier when I said we have a hypothesis. So our earlier work showed us that chewing up oxygen is bad. So my question then became, what if I can limit how tumor cells utilize oxygen? Would that allow immunotherapy to work better for more patients? And we actually just finished enrolling on this clinical trial. We got 31 patients enrolled, and we're in the process of analyzing the data. We then asked ourselves, similar to how I said, you go from stage 4 to 3 to 2. It's the same thing in translational science. I was, thoroughly convinced that the way melanoma cells utilize oxygen is very important in stage 4 disease. And my question became, well, is this important in much earlier stages of disease? So most patients with melanoma whose tumor is approaching 1 millimeter will have a lymph node checked. We call that the sentinel lymph node or first lymph node to see if the melanoma has spread there. And so I asked myself, if there is melanoma that has traveled to the lymph node, and that melanoma is chewing up the oxygen, is that bad? I don't know. That was a question that hadn't been looked at yet. And one of the things my lab has done is to really develop ways of staining tissue samples. So these are tumor and lymph node biopsies from patients that we had taken and brought over here. And you can see here that there are tumor cells, and that well, I'll tell you, the immune cells are sequestered on the outside and they're not able to come inside. And this seems to overlap very much with the areas of low oxygen tension. And we then asked ourselves, of all of the patients whose melanoma has traveled to their lymph node, is the melanoma chewing up oxygen, just like it does in stage 4? And the short answer is yes, absolutely, because we see less oxygen tension in the lymph node when melanoma has traveled there. And you know, at the end of the day, or at the beginning of the day, fundamentally, I'm a clinician. I take care of patients. And, you know, all of this science is really of no significance if it doesn't impact, of no significance to me, I should say, if it doesn't impact how patients are doing. So we then looked at this cohort of close to 100 patients, and we said, does oxygen in the lymph node impact how soon a patient is going to have recurrence or relapse of their melanoma? And the answer is a clear and resounding yes. So now, having been convinced that oxygen in the lymph node is important, we're actually running another clinical trial that I had written, and we actually just treated our first patient. He just had his surgery yesterday, so he had finished his treatment last week. And the hypothesis here is that by giving a drug early on and keeping melanoma from going to the lymph node and keeping the oxygen tension in the lymph node from going down, we are going to have less patients whose melanoma then goes on to metastasize. So this is a flavor, if you will, of the kind of work that we do in our labs here. And I'll just want to point out that, as I hope you can appreciate, more and more patients are getting treated with immunotherapy. I said, you know, stage 4, almost every patient's going to get immunotherapy. Stage 3, most. Stage 2, probably half and half. But one thing that's very frustrating to me as an oncologist is I have no way of knowing if a patient's going to benefit or not. What I mean by that is, if I have 100 patients, odds are, if 50 of them get treatment with immunotherapy and 50 of them don't, I know the 50 that get treatment, if you look at this statistically at a population level, they're likely to get benefit. They're likely to have less relapse. We've done these giant clinical trials with hundreds of patients and proven that. But if you look at this at the individual level, the patient in front of me, is this true for them? We really don't know. Because in spite of therapy, there are patients who relapse, and some patients who never get therapy never relapse. So I don't doubt the recommendation whatsoever that in general, people should be getting treated. But it would really help me as a physician if I could really be able to predict early on who's going to benefit and who isn't, because it would allow me to, first of all, spare patients toxicities if I think they're not going to benefit. Remember, with stage 4, I said it's 50-50 with our treatment right now. And we could maybe pivot to a different kind of treatment earlier on. So this is another question that we've really been trying hard to answer. And one way that we've been looking to do this is through the blood, because it's a lot less invasive. Obviously, you can, with a pinprick, get blood versus getting repeated tumor biopsies, which is not ideal for multiple reasons. And I just want to show you, this is data that I had presented at a national meeting earlier this year, that by looking at different levels of proteins in the blood, specifically glycosylated proteins, that just means that they have a sugar moiety sitting on the protein, there's a certain signature that we have that we think can predict quite nicely who's going to benefit from immunotherapy versus who isn't. And when I say benefit in this context, we were actually looking at survival. And this signature seems to work quite nicely. And so one thing we're working on now is validating these findings in a much larger number of patients. So the dream really is to continue to deeply study individual patient tumors to understand some of the fundamental differences between them, so that we can get every patient that 7.5-year plus remission that we're seeing, not just 50%, because that's, by studying the tumor, it's really the only way that we're going to be able to develop rational combinations of immunotherapy that we think may work. And what's really exciting about this time in the field is that I don't doubt at all that this is the tip of the iceberg. I said earlier that it never gets old when we think a patient is cured. I never thought I'd see it in my lifetime, and now we have the great privilege of seeing it all the time. And I don't doubt at all that the field is going to continue to move at this marathon pace. And I'd like to, because I shared with you some of our research, these are our various sources of funding, my lab, my collaborators' labs, and of course, everybody at the Hillman. First and foremost, the most important person to thank is always the patient, because I'm always bowled over by patients' generosity who are willing to undergo these biopsies simply so that we can learn. And with that, I will stop talking, and I will try and answer any questions that I can. Thank you so much.
Thank you so much, Dr. Najjar. And unfortunately, we don't have time for taking those questions right now. I want to thank Dr. Najjar as well as Dr. Ferris for their time. I want to apologize. I think for a lot of people, they weren't able to grab the screenshot of the QR code. So we will make sure to get that link along with the recording. So just want to give just a minute for Lauren to wrap us up with a couple of announcements.
I also just wanted to say, for anybody listening, please feel free to email me if you have any questions. I'd be happy to try and address them. Can I put my email in the chat? Okay.
All righty. Thank you so much, Dr. Baskin. So I am going to introduce 2 items. So if you're interested in supporting the melanoma program, you can donate through the link in the chat. I will include that link in there in just a moment. And then I'll also include a link for the Rush to Crush, which is coming up. And then you'll be able to register with that link as well. So thank you so much for that. As Dr. Baskin said, we are going to have to conclude our webinar at this time. So with that being said, you will have access to ask questions to both Dr. Ferris and Dr. Najjar, and you'll be able to receive information from that as well. So at this time, I would just like to thank everyone for attending this webinar, and we will be able to provide you a recording of this link and this webinar in the next couple of weeks. So as I said, I will include those 2 links for you all and in the chat. And at this time, you are free to go. And we thank you so much for your participation. And thank you so much to our fellow panelists as well.
Thank you.
Thank you.
Bye-bye.